Welcome to the RealPen podcast on federal government and the U.S. healthcare system. It seems like each time I start a topic with one of the six stakeholders, I always say, man, this is the most important uh, podcast I'm going to do. No, the federal government is huge. And here we go talking about it. The federal government carries huge short and long term liability for aging, disabled, underserved populations. It's unimaginable the magnitude of it. Several organizations project that the federal government has a deferred liability of 75 trillion, which is gigantic. Numerous changes exist around population risk as well as matching. That's probably the most important thing. How does something like traditional Medicare fit within small populations, which the country is covered with communities of small populations? We're going to go about it from a case study standpoint because it shows that all levels of government and collaboration amongst governments, communities, healthcare, employers, collaboration can get us there. We're going to look at Southern Delaware because there's an excellent template for local populations and services, ongoing relationships, and real pure customer service. It's a beautiful thing. And the case study is best described by the 2022 final report on the ACLINU Meals on Wheels program. So, welcome aboard, and we'll have some fun with this. We're going to quickly revisit the basic model of real population health because it starts with number one, as the customers, you're going to see that throughout everything we do, the addition of personal health nurses, which have ongoing relationships. These are not people that episodically show up at your house and punch some buttons and get paid more money by the government. Not at all. Ongoing relationships across life, social determinants, and connecting with primary care, which brings us to the team that actually is a mobile, functional, really, how do you even describe it? This can fit anywhere. So we're going to go through them one by one. In the situation in Delaware, we found that people we worked with, the few hundred we did, their circumstances are much worse. Their lifespan and life expectancy is short, and their needs change day to day, moment to moment. They need somebody to turn to. The need is absolutely big and there. The personal health nurse, because of nursing profession being the most trusted profession, an ongoing relationship with an RN nurse that's a personal health nurse deployed as that person on the front lines actually really works well. That relationship gives rise immediately to social determinants of health, and we'll see a couple of those. And then primary care realizes that this brings a continuum to care that's well past medicine, and it gives a smooth transition in and out of episodes of care within the health system. So that is how that works, and it's an amazing template for the federal government to bridge national, state, and local challenges. We have incredible results from the case study and ongoing services. One thing that's missing is there's not a way that we've aggregated claims yet, but that will be absolutely important to come. But what we've done is worked with nearly 400 individuals with 3.5 nurses over the last 5, 6 years. Those individuals, if you can believe it, use 271 different primary care physicians, and they have 14 different insurers. So when you think back to our original model, how on earth does the customers or the health systems survive and flourish with that much disparity? During this time, these nurses have had 22,000 plus interactions with those individuals from 20 to 24 through 24. Well, January 24 of 25. Looked that up that day. Mostly phone, much of it outbound. Two actual calls from today. You can read that and pull that down. But here's the nurse that's talking to him and said, "Oh, they need some grocery soup and juices and crackers. I'll take that by their on the way home. This is what we need." The next one is educated a person how to utilize their rollator and have their phone with her when she's going to the bathroom and in and out of bed. That kind of intimacy, it's just remarkable, needed, and it pays huge financial dividends. It is an amazing template for the federal government to bridge national, state, and local challenges in healthcare. Our federal government summary. Building federal programs bottom up with excellent health care for individuals just makes sense, except that we think top down. We want to sign a national law that does something nationally. Will not work in healthcare. It has to start one by one individuals, and starting with traditional Medicare is a great place to start. The metrics are there. Our population podcast, the number of nurses, primary care, and so forth, they actually fit. The number of nurses in primary care is uh, fit serving these populations. Now, we're going to find disparity in rural areas, but that's a different subject for a different day. How unique that RealPHN is helping stakeholders with populations in the hundreds, not thousands or hundreds of thousands. That's where it really works. Where does the money come from? In our pathway forward, it shows that there's plenty of money in the system from waste and unneeded inefficiencies of care. The money is there. It projected at nearly $1 trillion. Several circumstances tee up further successful. Delaware, the Maryland model, employers like Garrett, times are changing. Here we go. It's time to get going.